The following is a special video presentation of the Hennepin County Library.
Welcome. I'm Dan McLaughlin, Director of the Hennepin County Healthcare System, and today I have the pleasure of hosting a discussion with David Jacobsen, the author of Doctors Are Gods. You may recall Mr. Jacobsen's name as one of the hostages held in Beirut for 17 months. What is not widely known about Mr. Jacobsen is that he's a career healthcare administrator. In his new book, he and his son David take a hard look at the American healthcare system and some of the things we'll need to work on into the future. Welcome, Mr. Jacobsen, Minnesota, the land of 10,000 HMOs.
Hey, thank you. It's a pleasure being here, even though you have all the HMOs. But I understand they're of a higher quality than those we have in California.
Your book's got an interesting title, and most people respect doctors, but most of us don't call them gods. Can you explain your title?
Well, the title is catchy, and it's to draw your attention to the book. I've been in healthcare for 37 years. I've yet to meet a doctor who thought he was God, but I have met a lot who thought they were kings, and how dare you question my judgment? I have a divine right, off with your head. And as you're being in healthcare administration, you know there are a few kings out there.
Mm-hmm. Your book talks about a lot of personal stories of healthcare professionals. Maybe you can explain a little bit how you found the folks and what they said to you, and how did they come forward to tell you these stories?
This book is a series of anecdotes resulting from interviews with several hundred healthcare professionals, doctors, nurses, pharmacists, lab techs, and we use the Larry King style of journalism. We weren't journalists, but we used simple questions, and there were two basically, and they were: what is the most unethical thing that you've ever observed in healthcare? And secondly, what would you do if it was in your power to correct it? And from that, it flowed, and their comments would raise another comment. Our original chapter outline was discarded because when we assembled the book, in fact, we assembled it in an interesting way. My son and I lived 150 miles away. We each conducted half of the interviews. We wrote half of each chapter. We had one weekend to merge our files. We printed a hard copy. We realized that we had 600 pages for a 300-page book, and so then we came up with new chapter outline, new chapter titles. So the book was a little different than we had expected. It's really comments from the insiders. I have a strong feeling that 70% of the people in healthcare are decent, honorable humanitarians who give far more than they ever receive in return. These are the quiet majority. 25% of people in healthcare are sheep. They're going to follow any leader, good or evil, whoever is there. And 5% are impaired one way or another. And where we get in trouble is when that 5% is in charge of the 25%. That's when we got real trouble in River City.
One of the points you've made, I think, in your book is that there are problems in our American healthcare system because of some of the financial incentives, and much of healthcare is paid on fee-for-service. Maybe you can explain how that kind of distorts the system a little bit.
American healthcare is a business. It's market-driven. Physicians in private practice rely upon referrals, and sometimes they have to compromise their value systems to get referrals, and they have to remain silent. And we get into an area that the public just doesn't understand, and it has to do with privileges, delineation of procedures that can be performed. You know, we grew up in a society where television drama has made some major distortions. You know, we've had the Dr. Kildares, the MASH, and Dr. Marcus Welby. I tell people that May the 9th is my personal holiday that I take. And that's the day that Marcus Welby's television program got canceled. Now, Marcus Welby was a wonderful, compassionate, great man. He was a neurosurgeon, an obstetrician, a cardiologist. He made house calls. He would drive hundreds of miles to console distraught parents. He had enough training that in real life would have taken at least 40 years in residency to have done before he could start practice. He would have been retired under Medicare before he could, with all this training. It gave the wrong image. I think we, if we trace the development of medicine, the patient-physician relationships, and we go back to the early Greek era, their people wanted a physician who was their friend, and he was their friend. They knew the family, they knew everything about the individual. People accepted the fact that sickness was a part of living, that you do die. They were more interested in diagnosis, and they were more interested in an honest, open relationship and rapport. And as we go through history, we came into the priest-physician era, the Middle Ages. In fact, I think it was the first hysterectomy was performed, or cesarean section, about the year 500 by some monk. Then the priests were priest-physicians were more interested in saving your soul because you were filled with sin. And they were an extension of God. And so we get kind of the doctors are gods. And then we came up to recent times, up to World War II, and we had a nation of family practitioners with few specialists. They were people that lived in our community. We did not commute great distances. The doctor could live a block away. As a kid, the doctor that delivered me, I used to walk by his office on the way to the show or the candy store and just talk to him through an open window about any old thing. And people grew up knowing, well, you got a problem, go talk with your doctor, whether it be your health or your marriage or your financial problems or your school problems or whatever. So they were still your friend, they were your neighbor. The society has splintered, we live far apart, we are strangers in a crowd. We've had a tremendous and great development of technology and the development of specialists. Specialists do not have time to develop that rapport and to know Aunt Mary and Uncle Tom. And so there's a distance that has come in between physicians. Physicians are in private practice, most of them. It's a business. They're like salesmen. They earn money today, and tomorrow they start all over again. They live by referrals. Practices are built by reputation, by word of mouth, and they're destroyed by word of mouth. So doctors are under tremendous pressure to perform. They don't want to say anything adverse about their peers because they're going to might be cut off. So then we get into what is the real heart of the book on the reform issue. And most public they don't understand that. They assume that a doctor, when he graduates, is licensed as a physician and surgeon, can do anything and everything. From neurosurgery, he's a Dr. Marcus Welby, everything.
Right.
But he isn't. He has to go to residency programs. He has to have special training. And when he joins the staff of a hospital, he just can't come in and do what he wants to do. His procedures are determined by the medical staff.
Now, by the medical staff, you mean all the doctors of that hospital?
All the doctors of the hospital.
Right.
They decide, you're going to do surgery. These are the type of surgeries you can perform according to your education experience. This is the type of internal medicine that you can do according to your education experience. They put the limits as to what you can do. But the patient never knows that there are limits placed on his doctor and what he is competent to perform. Sometimes a doctor is given privileges that he does not deserve, and that's done because of social, political, or economic reasons.
What do you mean by they don't deserve them? They're not
They're
trained?
not trained to do it, they're not competent to do it. But they want to do it. They've gone off to Hawaii, they've done some scuba diving, they've attended a couple of videotape lectures on endoscopic procedures, and they come back with a certificate that they can stick a tube in every one of your orifice and do something for you. They're not competent to do
Now,
it.
why would a doctor want to do that? Is that for
Money.
financial reasons?
Money, sure. Some of those are, that type of individual is driven by greed. And that could be that 5 to 25% of the healthcare.
Right.
But that's true of all of society, whether they're administrators or accountants or
Sure,
lawyers.
sure.
I mean, we come out of the same pot.
But the hospitals have a system of trying to watch over those doctors.
We try to. And in the good hospitals, the major teaching hospitals, it's very effective. When you have a hospital where the medical staff is departmentalized, where the surgeons watch the surgeons and the internists watch the internists and the obstetricians watch, it works by and large. But when you have a smaller hospital, where you have a committee of the whole, where you have surgeons making decisions on what internal medicine procedures are to be performed and vice versa, that's where you get into trouble. If you get into some of the inner cities that are dealing with the very, very poor, those whose English is not the first language, who don't understand, who are frightened, who may come from a culture that believes a doctor really is supreme. You then do get some abuses. I think insiders and surgeon friends have told me that maybe 10 to 20% of all surgeries are unnecessary, really don't have to be done. And the feeding chain is enormous. The surgeon, the assistant surgeon, the anesthesiologist, all the consultants, the fees that the lab director, the radiologist, and the others will take, the pharmaceuticals, the supplies. We're looking at expenses of, who knows, it could be $12 to $25 billion in expenses for unnecessary surgeries. Now, I'm not saying every hospital does that, but some, it can happen in the less monitored and less controlled and less professional facilities.
Right. I've heard that sometimes that's more of a problem with rural hospitals, particularly, who are having trouble attracting doctors in the first place.
It can happen in rural hospitals, but it can also happen in the inner city that deal basically with immigrant populations. We know that there are abuses. We know, like in Los Angeles, they have bandito labs, non-licensed medical labs that do the lab work for the doctors in certain areas of Los Angeles.
Maybe that one of the more interesting stories in your book that I found fascinating was the Muskevich brothers, who set up some diagnostic things. And maybe you might want to recount that story, because I find that a fascinating abuse of the system.
These were the Russians, and they had their rolling labs. And I think one of them was a physician in Russia before he got into this country. And they would go out to supermarkets, to malls, to health fairs, to any place where there'd be a crowd, and they would do the lab work for you. And of course, they probably would take the specimen and pour it down a sink and come up with phony results. They would find out if you had insurance, and they would bill for it. I've forgotten right now how many millions of dollars of fraud, but I think they got away with, it was something like, they billed for $30 million, and one of the brothers escaped the country. He's somewhere in Europe, and I think they did catch the other one. But we know that happens.
One of the other fascinating consequences of that was that people, to get the lab test paid for, they had to make up diagnoses for the patients.
Oh, yeah, that's right.
And so some of these poor patients had this diagnosis following them
That's right.
their whole
they had
life.
to give a diagnosis so that the lab could be billed.
Right.
That got into the insurance files,
Right.
so many of them couldn't get insurance.
Right. So not only
Because they
did
had
they
a
get ripped off on
pre-existing
the doctors,
condition.
right, they had trouble with their insurance.
Yeah.
So I mean, those are, one of the questions that kind of brings up, though, is that we all kind of worry about a little bit from the kind of health screening wellness perspective that we probably all do need tests periodically to kind of see what's going on. And where's that kind of fine line between when a test might be ordered for financial reasons for the doctor and maybe for our own interest, for our health?
Well, I think that's where you have to have trust in your physician. You have to make certain you've selected the right one. You want to check on his credentials to see, is he trained? You want to see, who does he associate with in healthcare? Are these people of high, good reputation? You want to see what hospital staffs he belongs to. Are they prestigious, good hospitals? You want to see, you can always find out and go down to the county courthouse and find out how many times he was really sued for real cases. Many times doctors would settle just to stop the financial drain. It was a nuisance suit, and it goes down as, he settled. And that's an unfairness. But I have great empathy for physicians because they go through a lot. They have the same fears that we have. In fact, I think doctors fear death more than we do. They always want to disappear. Too much is expected of them. They are not permitted to make a mistake. Your mechanic can make a mistake, but you don't sue him.
Right.
And as long as the mistake is honestly made, I think it should be. In fact, this brings up this whole area of tort reform. One of the most powerful attorneys in the state of California who represent hospitals, I interviewed him. He's a friend of mine for a number of years. And I said, what are we going to do about malpractice? What type of tort reform can we have? And he said, well, if you promise never to reveal my identity, because my partners will kick me out of the firm, or they're going to throw me out of the window. And this was on a very high building. So there are three things we can do on tort reform. One is in the area of depositions and interrogatories. Do not permit them except in case of imminent death of a key witness. because they are nothing more than building the cost. They produce little or no new information, and they're a form of legal terrorism to force a doctor in to settle or a hospital to settle, or to split a doctor or split a doctor in a hospital. So eliminate depositions and interrogatories, malpractice. Secondly, put strict controls on contingency fees, and if possible, eliminate them. Because if somebody's really injured, it's obvious. You don't have to have a contingency fee. A good attorney will know he's going to win with a good case. And the third thing is make the losing plaintiff pay.
Yeah, I'm sure that would...
Three marvelous
right,
things.
Right.
But do you think we'll ever get that type of reform?
I don't think so.
I don't think so, but it's worth talking about.
But it is interesting in healthcare reform, we'll talk about that in a minute,
Sure.
but that is litigation, malpractice reform kind of gets talked about, but I don't think anything I've seen is real strong yet. Let me go back for a second here. I can't avoid not talking about managed care when you're here in Minnesota. This is, many of us think...
100,000 HMOs.
Right.
Especially with my chapter about...
I believe it was a hurry up, move them out.
Move them out,
Right, that was the HMO. What's your view on HMOs? Let me give you a little more introductions.
Sure.
Many of the doctors that I work with and doctors I know are kind of concerned about HMOs because they're losing the power in the system. One of the problems I think you've identified in that some doctors have too much control of the system.
That's right.
On the other hand, when they get in managed care systems, they tend to think they're losing their
The
authority.
pendulum can swing, and
Right.
that's where, in some areas, if they're not regulated, if they're not publicly accountable, if you don't have some way of reporting to the community how they're performing, you can have major problems with HMOs. You know, as we look at healthcare reform and bring it down to the very simplest basis, there are four key decisions that have to be made. Who's going to live? Who's going to die? Who's going to decide? And this is what upsets all of us. And who's going to pay? Because we're concerned with a system that has been driven by skyrocketing costs, which is a result of overutilization, more so than technology, I think, and duplication of services. But the skyrocketing costs, the overutilization. So how do we do this? As it is now, some of the HMOs, other than Minnesota, because I'm not conversant with what you're doing here, let's take the case of California. A major insurance company that markets an HMO product was a nonprofit organization converted to a for-profit. And in California, you got to take your assets and put it into a foundation, similar business. They put up $300 million to change their corporate structure so they could earn a profit. That's telling all of us out there there's big profits to be made in an HMO, at least in their concept.
Sure.
I think we have a problem, though, on deciding who's going to live and who's going to die, who's going to get treated, who's not going to get treated, because we are a nation of hypochondriacs. We are overweight. We don't exercise. We smoke too much. We drink too much. We do not take care of ourselves. We are unrealistic. We have too many demands to do everything for somebody who's sick. How many times in your career have you seen a whole family in the lobby moaning and groaning and mourning over a patient in surgery, and you find out they're having a relatively minor surgery that nobody's ever died from?
Right.
There's an overreaction. There's a demand that you do everything possible to save somebody who's in the twilight of their years with no quality of life.
Right.
I think our priorities are kind of mixed up.
That brings up another point that I wanted to kind of get to too, which was your book talks about, a lot of people have talked about the need for more primary care physicians, more primary care providers if they're nurse practitioners. And when we talk about that in our system, we wonder about the American tendency to say, well, I really want the specialist, you know. I don't want just some general doctor. I want the very best specialist in this particular disease.
Bring me the best. And you know, the American public through television and through movies has become they've become knowledgeable as to what the specialists are. If you have an orthopedic problem, you're not going to go to your GP, you're going to go to an orthopedic surgeon. A woman will go directly to a gynecologist. People search out specialists.
And the old saying sometimes is that if you go to a surgeon, you're going to get surgery. I mean, that's
Yeah, I mean that's they tend to think in surgical terms.
That's right. Now, I guess my question is how do you think we can reorient the American public to say,
Well, I think we have to start sharing some of the inner secrets of our industry. I think it's time we let the people know how the system really works, what authority physicians have in a hospital, what they can do, what they can't do, how they're disciplined by the organization, by their peers. I think we have to really start educating the public as to what is reasonable expectations. I know many hospitals in Minnesota have been in the forefront of wellness programs. We have to do more in that. We as individuals have to start living that lifestyle of being healthier and being more representative of what we should be. Would you believe I'm 85 years of age?
You're doing very well on the wellness side. Let's talk, we're here in the middle of 1994, so we need to talk a little bit about health care reform. It's been the hot topic. President Clinton has put forward a plan. Congress is debating it. Here in Minnesota, we've had our own health care reform called Minnesota Care, and you have
Tennessee Care.
Right, and many states, I believe, California's got a single-payer initiative that's going to perhaps
frightening. That has everyone ready to leave the state and move to Colorado.
Some people in Minnesota think we ought to go that way. So, I mean, there's a lot of stuff going on, but
Sure.
with all your thought about this topic and talking to all the folks in the industry, what's kind of your prescription for healthcare reform?
Well, I think, first of all, the discussion is wonderful. President Clinton is a master politician. His plans I don't think is going to pass because it's going to cost too much money, and there's a lot of political partisanship involved. But a discussion has been made, and it's an old management technique. You go to your hospital staff, you say, I want this done, I want it done this way. You get resistance, and pretty soon they're going to figure out another way of doing what you want to accomplish. Perhaps that's what the president is doing, is throwing out something that he knows is untenable, but forcing people to think about it. There is no doubt that there are some social injustices in our present system. Young married working couples with young children, uninsured, cannot afford to take their kids to a pediatrician. If you have one child or you have 4 children, one gets sick, they're all going to get sick, and they're all going to get ear infections. And 4 kids to a pediatrician can be $200 to $300 for the office visit and the medication, and you have a lot of ear infections. That's tragic. I think the wealthy people are taken care of. Those on Medicaid there's a way to get into the system. I think healthcare reform, whatever we come up with, will not be effective until we have adequate welfare reform. We have to acknowledge the fact that probably 1/3 of the people on welfare are there because our system has put them there and will keep them there.
Right.
We can think about the 2/3 how to get them out. I think we have to be creative on this fourth question. How do we pay? It's live, die, decide, and pay. How are we going to pay? We shouldn't just copy the same old scenario. We've been singing the same old song. We know we have problems with the insurance industry. We know we have problems with all of the entitlements and the taxes. Let's throw out a couple of concepts just to talk about, just to get discussion going. And again, I want to put a disclaimer in. I am not affiliated with any of the right-wing groups who believe that vouchers should be used for education. Okay. Perhaps we should think in terms of a voucher system for basic primary health care. Eliminate totally Medicare, Medicaid, and CHAMPUS. Replace it with a voucher system, with Congress determining a basic health care benefits package that all health care insurance companies must offer. And with that voucher system, an individual could go and buy basic health insurance. It would eliminate tremendous costs on health care. Can you imagine not having all the cost reporting that we have to go through in health care and all the specialists, the accountants, the CPA firms, the audits? Tremendous cost savings. About 25% of health care costs is probably the bureaucracy.
Right.
Tremendous savings. But think in terms of a voucher system where every American, then that's a single payer, in a way, would be getting coverage.
Sure.
Everybody get the basic. But for those who are achievers, those who want more, those who are working harder, taking care of themselves, maybe we should think about a supplemental program of a medical IRA.
IRA, like a individual retirement
plan, but have
Right.
it as a medical IRA, and your employer or you as self-employed, you could put money into this IRA that would buy that additional insurance, so you could have vision insurance, dental, other. But everybody would have catastrophic. Okay? Then if you take care of yourself, you eat properly, you exercise, you do the minimum of preventive maintenance that we all should do. We should change the oil on our car. We should get checked out, not on a periodic basis. Then that money that's not used could roll over into your retirement in the last years of your life. So it's a medical IRA is a topic of great philosophical discussion.
Sure.
Politically, the Democrats have a very hard time fighting with it. It's not being discussed, but it's something we should have a discussion about. The voucher with a supplemental medical IRA make people accountable and responsible for their own health.
Sure. It's kind of the model of a lot of personal accountability. I think much of what's in your book, it talks about that, both we as patients, we as buyers of healthcare, and we as healthcare professionals, for the two of us, having some responsibility for the system.
And we are responsible, and we have to start sharing some of the information we have, and we haven't been, and we can be blamed for that. The good people remain silent far, far too long.
Yeah, that's kind of maybe my final question is, those of us in the industry have always kind of kept it to ourselves, and you've written a book about it. Do you think there are other steps that we can all take to kind of open up the system more to the public?
Sure. I think we can just make a vow that we are going to be more open. We can start talking. We can have more programs like this. We can have more discussions. We've got to undo the Marcus Welby, Dr. Kildare image, LA law image. We have to destroy that. Because if people are going to make decisions, they have to have the facts. Healthcare, we have a good healthcare system today. It has problems. They are correctable. I'm concerned that if we throw it out, if we go to a managed care, private enterprise, fee-for-service, if the managed care costs a lot less, people will buy into that. It could be the destruction of private practice of medicine. And I'd hate to see that happen, because if it did happen, it could be irreversible. Then we would be unhappy. We'd be talking here 25 years down the road, not of the overutilization, but of what's happening with underutilization.
Sure. Well, thank you, David. And I want to thank David Jacobsen for discussing his book today, Doctors Are Gods.
A presentation of the Hennepin County Library.